Hi, Dr. Michael Miyazaki here again, and I'm actually excited, really excited about this subject because I'm going to talk about something I haven't talked about before, biofilm. Now, biofilm is one of those things that is hard for us to get our patients to understand, and sometimes even as clinicians, we forget about the importance of biofilm. So I want to go through just what it is, how to see it, and then how to get rid of it. And what you see on this screen are two tools that I use to treat biofilm and help my patients actually see what it is that we're trying to help them get rid of. Because it's hard when we tell patients, oh, you have to get rid of your plaque. That it's just hard. They can barely see it, and it just doesn't mean a whole lot to them. So that's what we're going to talk about. The healthcare system is such that it is hard to motivate patients. If they can see something like a wound or a cut, they understand that. If they see a growth or a tumor on their arm or their back, they can understand that. But there's things that our patients can't see. And remember, they're not healthcare providers. So if you say something like high blood pressure or you've got high blood sugar or you've got high cholesterol, it doesn't always mean a lot to a lot of patients because they can't see it. They might be able to feel the ramifications of that condition, but they can't see it. So it's hard to tell them, well, you've got to adjust your eating to keep your blood pressure down, or you have to watch your eating habits to keep your blood sugar in check, or you have to watch your eating habits to keep your cholesterol in check when they love to eat. So those are the things that we have problems with. And then we as dentists, we're trying to deal with disease, right? Periodontal disease, caries, decay. And we tell our patients, you got to watch how you eat to prevent periodontal disease and decay. And you have to help us keep areas of your mouth clean so that we don't have issues. But it all really comes down to biofilm. You know, we get biofilm built up around the teeth and it gets down below the gums and it attacks, or our bodies attack the bone to get rid of all that bacteria. So we have bone loss, we have gingival inflammation. That causes a lot of other systemic issues that we know about today. And that biofilm, if it sits on the teeth or between the teeth, it can actually cause decay. So, what is biofilm? Well, if I have one bacterial cell, it's like having a tent. It's just kind of isolated. So, wind comes by or toothbrush comes by and we can wipe that bacteria by. But biofilm is like a whole metropolis. Everything's now interconnected. There's good cells, bad cells, all kinds of hundreds of different cells living together. And after a while, they become kind of a complex community. So you got all these microbes that are all bound together, actually communicating with each other, and they're held together by this extracellular matrix that creates this sticky film. And that sticky film makes it harder to remove these bacteria. So it's not like having that tent that we can just wipe away. But now we've got a more sophisticated system that we're trying to disrupt. And you know what happens? We get in there with the instruments and we can disrupt this, but then it's going to repopulate over time and become this organized metropolis. And that's when it gets very hard to control. So all this bacteria can begin to develop underneath our gum lines in just 48 hours. So at about the 3 day mark, we have this biofilm that's been reestablished, or it is beginning to reestablish. Now, the microbiome in that biofilm may change over time, and over time become more of the bad bacteria than the good bacteria. And that's what we try to get our patients to understand, that we're going to get into that system, disrupt it, break it apart, and then it'll have time to build back up. But then before it gets in high enough numbers to do damage, we're going to kind of mess it all up again. So we tell our patients, one of the ways that we monitor the treatment is we take x-rays. And I don't know, we're in our practice, we get these patients where sometimes you would think that taking an x-ray is going to expose them to massive amounts of radiation. They don't want to do it, and they'll sign up on a waiver saying they understand the risk that they take if they don't have radiographs taken. Or maybe we have patients that are undergoing cancer therapy, so they're having radiation therapy, and they just figure because of that they're exposed to a lot of radiation. And when we say, hey, we need to take a radiograph with ionizing radiation, it's something that they don't really relish. So, we're always looking for ways to take care of our patients in a conservative manner. And if we can diagnose things without having to expose them to radiation, hey, we've got today some tools that we can do this with. One of the tools that we have just begun to incorporate into our practice is biofluorescence technology. And what the biofluorescence technology does, if you look at this upper right hand side, is as we build up plaque, and that plaque gets to be about 3 days old, you will start to see there's a property of that plaque that we can actually take advantage of. And that is it begins to fluoresce. It has these porphyrins that are markers for that bacterially infected tissue. And as it matures, it becomes even more apparent. So what you see here on the top side is you see white light images on the top row, and on the bottom row you see biofluorescent images. And we're at the 1 day, 2 day, 3 day, 4 day, 10 days, all the way over to the right. And what you start to see is about the 3 day mark, we start to see the fluorescence of that bacteria. So we can begin to visualize that polymicrobial population because of their porphyrin fluorescence. And so in our practice, we've used different types of fluorescent technology for years. One of the things that we still do every day is we use our Velscope. So again, Velscope helps to detect oral cancers. We've used other instruments like the Diagnodent for years, and other caries detectors that actually use different lights, like either lasers or different light frequencies to detect decay. So this technology isn't new, but it hasn't been readily available. And so what I'm going to review with you today is 4 different pieces of equipment that we are, again, beginning to use in our practice to really help us diagnose and see what it is that's going on in our patients' mouths. But I think almost more importantly, helping our patients see what's going on in their mouths. And we're doing this with just light. So we talked about that ionizing radiation. We don't have to expose the patients to that ionizing radiation. We're just using basically regular light. So this is one of the cameras. It's called the LinkedIn's QC camera, and it really allows for easy full arch imaging. And so we can capture full upper and lower arch, right side lateral, left side lateral, and occlusal photos within about 30 seconds. And I'll actually show you how that works. Camera is very light, plugs into the computer system. There's an independent software that runs adjacent in our practice. Our practice management system is EagleSoft. So we run it adjacent to that, but then we can easily import the images. I'm sure over time, because this technology is just trying to launch in the US, it comes to us from Korea. And I'm sure over time, as there's more and more users, they're going to patch it so we have a more direct way to patch everything together. But what we're able to do is using this biofluorescence, I'm just going to use a laser pointer over here. So what we're able to do is, you see here, this is an image using biofluorescence, and where you have the red, those are areas where there is a biofilm in that area, or it could actually indicate cracks in the teeth because there's biofilm in those cracks, and I'll show you that more as we go through this. So what we're doing is we're using quantitative light-induced fluorescence, it's called QLF, to see the fluorescence and quantify what that means by comparing, like an enamel, the demineralized area with the regular healthy tooth structure or enamel around it. And we can detect biofilm, and by using these and correlating them, we can pick up areas of early dental caries and areas where we have gingivitis and possibly periodontitis. So we're using a blue light wavelength, 405 nanometer blue light. We use special filters to filter that and see the red glow. So these special filters make it possible to observe the loss of fluorescence from defective areas of the hard tissue when we have caries and even worn tooth structure, and to observe that red fluorescence from bacterial deposits, typically when they're 3 days or older in the patient's mouth. And so we have the porphyrins, and the porphyrins will give us this red fluorescence. And again, we have to use these specialized QLF filters to convert that blue light source as it reflects off to see the red. And it's very easy to use this equipment. Here is the big camera. And this camera is really kind of cool because it's so light, and you can see we can get a straight on photo. We can get, like you see here on the right hand side, kind of a right lateral area. Now in this photo, you can see that we have some visible plaque and really red gums. To a patient though, it's not easy for them to see that. So what we do is we illuminate that with our camera here, and we're able to show the patient, okay, the white areas, that's where your teeth are in good shape. And then where that red is around the gum line, that is the plaque and the biofilm. That's the bacteria that has created this metropolis around your gums and your teeth. But unfortunately, all that waste product is causing decay in your teeth, and we're causing a chronic inflammatory response in the gums, the soft tissues, which cause inflammation, bleeding of the gums, bone loss, but then it also has systemic effects. So today, most dentists and hygienists, we're trying to pull in the oral systemic value of taking care of your gums. So here's the camera. You can see on the back, there's this built-in viewfinder, and we can easily bring this up to the patient. I have retractors in the patient's mouth as we pop the photo. This camera is taking two photos. It's taking a white light photo and the red filtered photo, so we can see the biofluorescence. So I took the straight on, take the right lateral photo, take the left lateral photo, and now we're coming in, we're taking occlusal views, so we could take a look and see if there's any decay in some of the nooks and crannies of the patient's teeth. So you can see it's very, very fast. In our office, what we're starting to do is we're starting to adapt our workflow. So in the past, what we would do is the patient would come in, and we would use a camera, maybe a DSLR, to take kind of the same photos that we're taking here. Well, in order to simplify this for the team and to decrease the amount of duplication, this camera is actually taking some pretty nice photos. So instead of using our DSLR for our new patient exam when we're kind of in the diagnostic phase, we're just using this camera. It captures really good images, and you can see on the viewfinder, that's the white light image, and when we take the photo, you can see that the red filtered image will show up. So again, it's hard to take a video of this. Now here's another close-up, kind of taking over my shoulder, where you see that red on this central, that the patient's left central, but our central on the right, where you see that red, that is where we might even have marginal leakage onto this restoration. So very hard to see until you actually light it up. So that is a very fast way of taking the anterior, right lateral, left lateral, maxillocclusal shot, mandibular occlusal shot, and we just put that in the patient's records. Now remember, I was telling you we do usually take some DSLR photos, and so I'm just going to do that at the time we do any type of treatment. If we take treatment or do treatment that I want to document, we'll go ahead and use our big fancier camera. But these photos are actually really good quality photos just for your chart. Then we have the linked Dens QP. It's basically an intraoral camera. So a lot of you have used intraoral cameras, doesn't take any special training. And again, I have the retractors in there just to make it easier to record this. And as I go through, there's a little button right here on the camera. You just hit that button and it captures the image. So again, it's going to capture that red fluorescent image and your just white light image. So we'll have both to go back and look at and review with the patient. So remember, I had the big camera, and that's kind of get the arch views. And now we can go in with this little camera, and I can get the occlusal surfaces and really narrow it down to specific areas of the teeth that I want to focus on. So what you might do, and eventually they think this technology may get to the point where we use these types of cameras and we scope the mouth out. Now when we scope the mouth out, if we saw an area where there's a lot of red in that area, possibly because of decay, even interproximal, that's where we would take our radiographs. So if you have that patient that says, hey, I really don't want radiographs, I would say, okay, let me go through your mouth with this non-ionizing camera, right? Let me show you as we're taking these photos, what you'll see is the images actually look a little blurry as you're holding the camera. And then when you actually hit the button, it autofocuses really quick. And you'll see it'll take that white light photo, and then you saw the second photo, which is the red light photo. So you can see that Sometimes you'll get it in there and you can see that the camera is a great camera, but see that last part of that photo? That's kind of that red light image. So this is just really good because you can give the patient a tour of the mouth. You can show them those old fillings. You can show them the cracks, and the cracks show up much better with this camera because if there is a crack and there's any biofilm seeing that crack, it's going to glow red. So here's a tooth where we take that pen camera, we capture the first white light image. It looks pretty good right there, right? It's hard to really see anything. But then the second image that it takes, remember you just hit the button once and it's taking both images. You can see this red line crack. And what that is, that's a fracture in the enamel where bacteria is getting into that crack and it's aged over 3 days. And now when we take our camera in there, it's showing us the crack and it's much more visible. So over here, let's paint a scenario where the patient says, you know, every time I bite down or I eat on this tooth over here, it really hurts. And now you take your white light intraoral camera in there and you're looking around and you're right, it is hard to see. What I might do at this point is pick up my pink wave curing light, put in the trans illumination mode and see if I could light this guy up. But it's going to be white light. So sometimes you can see it and sometimes not. But what if I'm using this pen camera, intraoral camera, and I'm able to show the patient this? Now that is motivating. If I'm the patient and I see all these little cracks running through this tooth, and then I would then, as a clinician, do my tooth sleuth, have the patient bite on it. If that elicited pain, I would be thinking that this tooth needs some kind of work before that big piece of enamel fractures off. But this camera is great. It's just easy to use. You get your white light image that you see here on the left-hand side, and you get your right side image that illuminates all that biofilm on the right-hand side. So if you were the patient, you can see the left side. You can kind of see the wear and tear going on, but the right side to me would be much more motivating. So I was telling you that I get excited about this presentation, and there's two reasons. One is now I've got ways to look at biofilm, because even on a radiograph, I can't see the biofilm necessarily. What I see on the radiograph is the after effects of the biofilm. When I can see decay on a radiograph, then it's almost too late, right? I have to figure out what I'm going to do, but there's some kind of reparative work that's going to have to be done. If I can show the patient where the biofilm is collecting at the gum line, where the gums are red, or maybe on a tooth where there's not a cavity yet, but in the grooves and those little pits, those will light up bright red with this technology. I can tell the patient, hey, you know, these are areas that maybe we can try some remineralization gels to kind of improve that integrity of the tooth structure in that area, or we might have to do a restoration. But what I'd really like to do is focus on doing something preventative. So we know the bacteria is collecting in these areas around your teeth or on your teeth. And what I want to do is I want to make sure that the condition doesn't worsen, that we don't get periodontal disease and we don't get decay requiring restorative work. So what we have done in our office is we use Paraprotect. And there's things about Paraprotect that are going to make it even better towards the end of the year. But if you look at this research or this paper that was written by Dr. Keller, he just states that periodontal health exists when we have better bugs than bad bugs. And the gingival sulcus is about 3 millimeters, basically. So I'm kind of summarizing it. But periodontal disease occurs when there's a change in that microenvironment. Remember we talked about, we had that metropolis that's all communicating, but now the bad bugs are becoming the majority. And there's an imbalance of good bugs and bad bugs. And now we have more bad bugs. So what do we do about the bad bugs? Well, we deliver hydrogen peroxide down into the sulcus. And I tell my patients, when they've got 2 to 3 millimeter pockets, if they don't want to do paratrays, they don't have to, but they have to brush and floss really well. But as soon as those pockets start to get 3, 4, 5, or anything greater than that, I tell the patients, you know what's happening is the bacteria is working its way down this little sulcus. And as it works its way down the sulcus, it's becoming impossible for you to get to. And that's why we're having you come in every 3 to 4 months, or sometimes even 2 months, because the buildup is so bad. But the pocket, the depth of that little crevice between your gum and the tooth now is 5 millimeters deep. And even if you have the best flossing and toothbrushing techniques, you only can get down maybe 2 or 3 millimeters, which means that we've got 2 or 3 millimeters of bacteria that's just sitting down there that never gets disturbed. And they develop that really fancy civilization of interconnection, and they want to survive. So what we have is we have an option. You either get more disease, you come in more often, or we can give you these trays. What these trays are is they are FDA cleared medical devices manufactured so that they have a customized seal that compresses the wound, and then to overcome the crevicular flow of fluids coming from the tissue out towards the mouth, what we're going to do is we're going to put perigel in there, and because it fits so tightly, it generates 5 times the oxygen saturation, which then gets rid of the bad bugs, and we get more good bugs. And so what you'll start to see is that your gingival inflammation will go down, your breath will be fresher, and you'll start to have whiter teeth, all because of the paratrays. So these paratrays are a minimally invasive way of taking care of disease. So I have some dentists, and they say, well, how do you get your patients to accept paratrays, because they're not free, right? The patient has to pay for them. So I tell my patients, when you start to get those 4, 5, and 6 millimeter pockets, the paratrays have been shown to get hydrogen peroxide down 9 millimeters. But the other option is, if we can't maintain that tissue and we continue to lose bone, or we continue to have inflammation, which isn't good for the rest of your body, then we have to have surgery. So either you invest in the paratrays, or we let the disease get worse and you have to have surgery. And at that point, it's up to the patient. I'm not going to force them to get paratrays. So it's up to them. But what we're trying to do is we're trying to get them to understand that when they floss or brush and their gums are bleeding, there is this connection between their soft tissue health and their total body health. And if you have a lot of inflammation, it can contribute to atherosclerosis, strokes, Alzheimer's disease, type 2 diabetes, obesity, rheumatoid arthritis, and there's this systemic connection of having coexisting inflammatory conditions, and we want to get rid of that. So what we use is the paratrays to address the etiology, which is the biofilm, which is what we can see with the cameras, and then that non-invasive methodology of detection and then treatment and then monitoring works out really, really well. I tell you, I'm going a little bit long on this. So I've only gone through 2 of the pieces of equipment. So we're going to call this part 1, and then we will have a part 2. But if you like this information, or if you find this information helpful, then please hit the like button or the subscribe button. We bring you something new every week. And we are trying to develop this community of like-minded clinicians, trying to do the very best for our patients. So hit like, hit subscribe, and I'll see you on the next episode. Thank you very much.